Hello, listeners. Welcome back to the Digestible Podcast, where we give you all the health and wellness information you need in an amount of time that your busy day can handle. And we make it easily digestible. I'm Stacy, along with my co-host and sister, Melissa. And I have to ask you this question, listeners. Do you really understand your cholesterol and all the pieces and parts of those numbers you see? Do you know what a cardiac calcium score is? Have you had a cardiac calcium score test? And can you tell the difference between having a panic attack and a heart attack? I think these are questions that we all need the answers to.
Which is why we have Dr. Micah Eimer. Dr. Eimer is a cardiologist on staff at Northwestern Medicine. He graduated from New York University and Northwestern University Feinberg School of Medicine. He also serves as the medical director of 3 outpatient centers, and he's the director of the internationally renowned Northwestern Medicine Summer Pre-Med program. His practice is general cardiology, although he has an expertise in sports cardiology. And boy, oh boy, we had a great conversation. We learned so much. We laughed a lot. He's a
great
ham.
guest.
He's fantastic. We hope you enjoyed this episode and you learn a lot about your heart health.
And share it with everyone you know. Dr. Eimer, welcome to the podcast.
Thank you for having me.
So let's start off with you telling us a little bit about what motivated you to become a cardiologist.
Great question. So it's a lot of things. You know, it's some of those include the fact that there was a family physician that we had in my family who was a cardiologist who, you know, we talked about incessantly. And my grandma was really great about having family dinners at her house every Sunday, right? So she was a great old world, like baker, cooker, just banged out meals for 20 people like it was nothing, right? So every Sunday we'd be at her house and we'd be at this big long table and all we would talk about is Dr. Stone. And I'm a kid, I don't know anything. And my grandpa's, I want more potato salad. And everybody, oh, what would Dr. Stone say about that? You know what I mean? And I'm like, who is this Dr. Stone? And why are we constantly talking about him at our family gatherings? And so I think that made an impression on me that I wanted to be like important to people, like be involved in their lives and try to help them, you know, navigate through their lives and through their health and that. And I don't know, I just really like people. I just really like working with people and solving problems. And you know, cardiology, why cardiology is just, it's a common problem. Like, I mean, like you ever been on an airplane and they're like, is there an ophthalmologist on board? No, that never happens, you know? And so I wanted to be needed, like to have a disease process that was common, and, you know, serious enough that it was serious. And, you know, we all kind of go through this process of how do you pick your specialty? And one of the things I tell students is you gotta find a comfort level with acuity, right? So, you know, on the one hand, are you the kind of person that's like, oh God, I really hope they don't ask for a doctor on the plane, and you're like staring at your shoes, right? Then you probably should go into radiology, right? Nothing against them.
Right.
Right. Or if you're like, yeah, let's go, I'm ready, you know, then you're more into more of a specialty like cardiology or, you know, intensivist or something like that. So it just kind of fit for me. And by the way, fast forward 25 years, I now work with Dr. Stone together in the clinic.
That's
Yeah.
nice.
So it's just an amazing opportunity.
That's such a
Full
nice
circle. That's so
story.
nice. Yeah.
Thank you.
That's
Thank you.
great.
Well, as a cardiologist, what would you say is one misconception about heart health that you wish everybody understood?
Okay. So here's the thing. This is what I would say is that just because you look good and you feel good doesn't mean that you are good, right? So, you know, everybody, they're kind of waiting, well, I don't have any of this, I don't have any of that, I'm healthy, I don't smoke, and that doesn't mean anything. That doesn't mean you can't have significant or fatal heart disease, right? It just means that you feel okay at the moment. We are really not great at finding people who have risks that they don't know about. I mean, we'll talk a lot about it today because I think we do have some ways to do it. But my biggest, misconception out there, I think, is that people think because they exercise and because they're not having chest pain, and they don't smoke, that they're not at risk for heart disease. And that's really, really not true.
That seems like a really important thing for people to hear.
Yeah.
So since you mentioned exercise, how much exercise does the average person need for heart protection? Is there a formula for that?
I mean, you kind of have to tailor this to a patient, right? So if I'm in front of a patient who's like, I know is writing down everything I say, and they're like, at this many minutes, at this many heart rate, and this and that, I'm not a big believer in all that, right? I think what you want to do is you want to get sweaty, get a little short of breath, right? Be looking at your watch, like, when is this going to be over? Like, that's how you know you're exercising enough, right? And how much? I mean, the more the better. There's no, in the amount of exercise that normal people do, there's no, like, you never go over the benefit curve, right? I mean, there probably is a curve like that. And I think people that do, ultra marathons and marathons, I think they're pushing their luck sometimes. But for the stuff that normal people do, the more the better, right? So like me personally, that's always a good one, by the way. It's like, what do you do, Mr. Expert? You know what I mean? Mm-hmm. And me, I have a 25-minute stationary bike regimen that I do every day, almost every day, that I think is just perfect. It's like, over the years, I've figured out that I always have 25 minutes. And if I can do more than that, great. If I can't, I feel like I did my job. So, goal for people, I would say, is 30 minutes 5 times a week. That would be great. But I'm happy with any kind of exercise that anybody can do. And it doesn't have to be in a gym. It doesn't have to be anywhere special.
Okay. And have you heard of like the zones? Like there's zone 2 and there's zone 5.
Yeah. I think that's a lot of nonsense. Although I will have to say, have you heard Orange Theory? I did Orange Theory for a while. Have you heard of that?
Yeah.
That's with the zones and your heart rate's like up on the thing. They tried to kill me. I don't know if they sponsor your show. I don't know if they do sponsor your show. If they do, we can cut that out.
No.
And I can.
No.
And they definitely won't now, even if they wanted to.
Well, okay. So you don't want to get killed, but it sounds like you got to be uncomfortable. 30 minutes, 5 times a week, and like you're like looking at your watch and be like, when am I done with this? And intervals can be helpful too. Like if you get your heart rate up and then down.
Totally. And again, the more the better. And the higher the heart rate, the more benefit you're getting. No doubt about that, right? But what you have to balance is if the workout is so unpleasant, like if you're pushing yourselves to heart rates and zones that are so unpleasant, you're never coming back. So I did Orange Theory for a year and I couldn't stand it. I hated going and I never went back. And so I think you try to talk to the person. What is your goal, right? So if your goal is, I want to be healthy, I'd like to lose a little weight, I want to stay in shape, I want to feel good mentally, then just do whatever. It doesn't matter. If your goal is, I need to improve my mile time in the marathon from 8 minutes to 7 minutes, 33 seconds, then you need to be hitting certain targets and goals but that's not normal people, right? Like the average people that I see just need to just get moving and sweat a little bit.
So it's consistency, regular movement, at least 5 times a week.
Yeah. And I mean, I have comebacks for every excuse, right? And so, the patients are always like, oh, I'm too busy, or I'm too tired, or I don't have any place to exercise, or I can't afford it, or like, it's all nonsense. I mean, you have to pick something that is easy, and that you can replicate, and the benefit is in replicating it, right? It's not like in the massive workout every 6 months. That'll kill you, actually. That's not good for you at all. The benefit is in the 20-minute workout that you can do 5 times a week, So like I said, for me, what I figured out is I have in my basement, a stationary bicycle that I go to. I wake up, literally my alarm goes off. I go down there in my underwear, which is unpleasant image, I know, but it's easy, it's fast. I don't even have to worry about putting on exercise clothes. And then after 25 minutes, I throw my clothes in the laundry and get in the shower and go about my day, and that just works for me.
Yeah.
That's great.
Okay.
All right. So that's some
great.
very real, good, solid advice.
Thank you.
Talk to us about the cardiac calcium test score. What it is and what does it predict? And if the scores are bad, what do you do?
Yeah. So I love the calcium score. I love it, love it, love it. I really, I think it's a test that gives us insight into something that there's no really other way to get the insight. So I talked about in the beginning about how people can walk around thinking, I feel good, I look good, I work out, I'm in good shape. And you may be harboring all kinds of coronary artery disease that you don't know about. And how is that possible? Well, coronary disease, the way that people die from heart attacks, right, is the plaque blockages in the arteries that progresses. And it either progresses in a kind of slow, controlled way, 50%, 60, 70, 80, 90. Okay. If it's below 90%, you don't feel anything, right? How is that possible? It's possible because our arteries are very smart. And when they get a blockage in them, they dilate, they enlarge to work around the blockage so that the blood flow is not affected at all. And that works up to a 90% blockage, and then the arteries are fully dilated all the time. And when you try to climb the stairs, try to exercise, your heart says, whoa, 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 we're not getting enough blood flow. You get chest pain, okay? Those people come to me. They say, when I climb the stairs, I get chest pain. No problem. We know how to fix that. But what kills people are the ruptured plaques, right? So you have blockages that are in the 40, 50% range that have no ability to cause you any symptoms. So you have no idea they're there, right?
Okay.
And then unpredictably, they rupture. The plaque ruptures, the cholesterol and stuff comes out into the artery. It forms a clot, which occludes the artery. And that's a grabber. That's like, can happen anytime, when you're exerting yourself, when you're sleeping, anytime.
Okay.
And the problem with those, like I said, is you don't know you have that until you have it, right?
Right.
And
so, go ahead.
No, I was just going to say that's where the calcium score helps, right? Like it'll tell me, no, you have coronary disease, even though you feel fine and you're working out, you have coronary disease.
And it's just a quick X-ray.
Oh yeah. It's the quickest thing in the world.
Scan.
It's
a scan.
It's a CAT scan, right, of your heart with no contrast. It takes like 10 seconds. It costs, different places charge like $50, $60, whatever, which most people spend at Starbucks in a week. It's nothing,
Right.
And it's just a ton of useful information. By the way, who is credited with discovering this? Probably don't know this. Arthur Agassiz, the South Beach diet guy.
Oh, interesting.
Yeah. That is interesting.
Yeah.
I first heard about it a few years ago. I was at a fundraiser for the American Heart Association, and one of the people that came up to speak was this guy who used to run. He was a runner, and he was like probably in his 40s or something, and had a massive heart attack. They're like, what? Why is he having a heart attack? He's a runner, and his calcium score was super high. Yes. They didn't know. So they're like, get a calcium test. Everyone's got to get one. So I had a calcium score of 0, which was really exciting. But I have a friend whose calcium score was like 100.
Yeah.
Wait, how does the scores? Yeah, how does that work? I didn't realize it went that high.
Okay, so here's how the score works. I've seen thousands. Right? So the way that this works is when you have plaque in your arteries, it causes inflammation, right? And your body has sort of a stereotyped way that it handles things it doesn't like. Injuries, inflammation. It just throws calcium at it. Like, think of it as like wall cementing off something, right? So like if you pull a muscle, if you pull a tendon, your body will calcify it. That's how it sort of reinforces things. So you get plaque in your arteries, your body throws calcium at it. CAT scans are really sensitive at picking up calcium. So if we pick up calcium in the vicinity of your coronary arteries, there's only one way it got there, and that's because of plaque. Now, little side note, runners have a lot more coronary calcium than other healthy people do. And
interesting.
It's a little controversial. Some people think because that's injury, right? And this isn't just like casual runners. This is like marathon runners, ultra marathoners, right?
Okay.
So they're, again, getting back to my original point that there may be a certain amount of exercise that goes beyond benefit and into harm. And some people think that's what that is. But for the vast majority of us, if you have calcium in your arteries, it's because you have plaque in your arteries. And so the score counts all those little specks of calcium, and the number of specks gives you the score. It's called an Agatston score. And the score goes anywhere from 0 to a couple thousand or something.
Okay.
And the lower, I mean, in my opinion, in my practice, you're 0 or you're not, right? Which means you have no calcification or you have coronary disease. And, in my mind, there's no safe amount of coronary disease, right? It's not like, oh, I only had a 50 or 100, I'm fine. No, all you need is any amount of plaque to have a heart attack and die. So I see the whole world as 0 and non-zero.
That's really helpful.
Yeah. Sorry, is non-zero like a statin, like a guaranteed statin, or what do you do when someone's not a zero? Okay.
Yeah. I mean, that's so in my practice, if I can prove that you have coronary artery disease, we treat you like we know how to treat coronary disease. All the interventions that we have that lower your risk of having a heart attack or a stroke or dying from heart disease, which includes statin to lower cholesterol, baby aspirin for most patients. And then let's look at everything real closely, like what's your lifestyle like? Are you exercising? Do you have diabetes or pre-diabetes? How's your blood pressure?
So what increases the plaque and what decreases the plaque then? Like, how can you fix it with lifestyle changes? Obviously, you were talking about that, but.
Yeah, I mean, you can, and you should. I mean, that's never the wrong answer. But I think from my point of view, I have things that I can use that are proven to reduce the risk in addition to lifestyle, right? So the right answer is always, medication plus lifestyle changes. And I have patients a lot who say, I really don't want to take medicine. I want to try to do this with lifestyle. And there's a couple things. Number one, your cholesterol does not respond that much to diet, right? I'll just say it. It just doesn't, right? It's very genetic. A lot of these things are very genetic. And, if you eat grass and rainwater for a year, you might still have high cholesterol. You know what I mean? So it's just not possible in a lot of situations. That's number one. Number two, we know that on top, whatever you can get your cholesterol down to, I can get it lower with medication, which turns into lower risk. So why wouldn't you do that? So sometimes you got to let patients come to it, right? Like takes them a while, years maybe. But the right answer is lifestyle plus medication.
Okay. I guess that feeds right into our next question, which is, let's talk about cholesterol. There's been so much, I think, change in how people talk about it and understand it. Start at the beginning, like break it down for us, the total number, all the pieces and parts, and what we're really supposed to be looking at.
Yeah, so I think the cholesterol story is just the story's getting more complicated, right? There's always more, and every so often there's another particle we're supposed to worry about and another thing that's connected to outcomes. And, so just to back up, we used to talk about total cholesterol under 200, right?
Right.
And the problem with that is that total cholesterol also includes HDL, which is good cholesterol, right? So in your standard cholesterol panel, you get total cholesterol, which is the sum of everything, right? Plus there's LDL, or low density lipoprotein. That's bad cholesterol. There's HDL, which is high density lipoprotein or good cholesterol. Then there's triglycerides. And, it's not useful, in my opinion, to focus on total cholesterol. I think what people should focus on is, number one, what's my LDL cholesterol? Because that's the number one thing that drives risk. And just to complicate matters, in our field, we've been changing the rules about LDL goals. And the reason is that, when the statin trials first came out in patients with heart disease, we said, all right, let's get that LDL down to 130, and that'll be great. And we did it, and it worked. Okay. And then somebody said, what about 100? Let's get it down to 100, even better. How about 70, even better? And so this curve just keeps going down and down and down, and we have yet to find a point at which there isn't more risk reduction with further LDL reduction. So now we're talking about LDLs in the 30s, right, for really high risk people. So I still think the main focus of cholesterol and cholesterol therapy is getting the LDL down, right?
As low as possible.
I mean, yeah, like I said, I am uncomfortable going below 35 just because we don't have a lot of data there. But I definitely have patients who are high risk. So, for example, a young patient in their 50s who's had multiple heart attacks, multiple stents, getting high, like that's the kind of person you throw everything at, and you get their LDL down into the 30s. And we talked about statins, but it's not just statins anymore. We have a lot of options on how to lower cholesterol. So we can get your cholesterol as low as we want to. We're not limited by the medication anymore, right?
Okay. And is the higher the HDL, the better, or is there like a limit to where it's like
exactly right. So the higher the HDL, the better. Now that's a really interesting story, because it's a classic story of correlation and causation, right? And so when we figured out that the higher the HDL, the lower the risk of heart attack, the natural inclination was, well, let's make drugs that raise HDL, and that should prevent heart attack, right? And we forced horrible drugs on people for decades. Niacin was one of them. And I don't know if you remember that. Maybe your parents were taking niacin. It was a horrible drug. I mean, it made people turn red and itch all over, and it was miserable. And, we would berate them for not tolerating it. You have to take it. It's going to lower your risk. And guess what? It did a great job at raising HDL. Like your numbers, like pat on the back, like, hey, your HDL was 35, now it's 45, good job. But when you look at the actual data, it did nothing to prevent heart attack and stroke and dying from heart disease.
Oh,
so
it did nothing.
Did nothing. Total waste of time. And several
because
other
lower LDL is what the lower the
no, I think it's because HDL is a marker of healthy living, right? So what raises HDL?
If you're artificially raising it, it's not really it's the healthy living that's the key.
If you get there by doing the hard work, you get the benefit. If you get there by taking a pill, you don't get the benefit. So it was a classic.
Interesting.
That is
classic.
interesting.
And there's another one that we'll probably come to right now that we're kind of going through the same thing. So HDL I think is super important, but what it tells you is how's my lifestyle, right? Like how am I living? And the patients that have high triglyceride and low HDL, they're not living right. That's a lifestyle problem. Right.
Aren't triglycerides, I'm sure you're going to move on to that next, created from sugar? Like a lot of sugar in your diet and processed foods and stuff?
Patients that weigh more than they should, patients who have diabetes that's not well controlled, patients that drink more than they should, they will have this pattern of high triglycerides, low HDL. And I call those the lifestyle lipids. That's telling you, hey, you got to do better. You got to do
the lifestyle lipids. And those are indicators of things. The LDL can do some damage if you have too much LDL. Are the triglycerides also doing damage, or is it just the marker situation?
Not really. I think it's more of just a marker of
all the other things going on.
Overall vascular health. Yeah. I mean, the plaque, if you look at the plaque, like what's causing the problem, it's LDL. It's the LDL that accumulates inside the arteries and causes the problem. And I think that's why it's most tightly linked with events. But HDL and triglycerides are like, what's your overall health? So in other words, if you had high LDL, but good HDL and triglycerides, maybe you avoid a heart attack, right? Because even though your LDL is higher, the rest of your system is better off. And it's just all these interplay of all these different variables.
But doesn't our body need cholesterol for certain things, like protective, like our brain
Definitely does. Yeah. But I think that your body is smart enough to know kind of where to use cholesterol and where not to use cholesterol. And by the way, when you look at all the trials that I mentioned at lowering cholesterol, none of them have ever shown any significant adverse events with respect to, people worry about Alzheimer's disease, dementia, cancer, the way I tell patients is if you aren't going to drop dead of a heart attack at 50 like your dad, you might get Alzheimer's, you might get cancer, right? You're gonna get something's gonna get you. So I don't think it's that these things cause it, but I think they allow you to live long enough to get other diseases.
Okay.
That makes a lot of sense.
So let's talk about, Stacey, you're going to have to say this one because I don't know how to say it.
The ApoA and the lipoproteins. Yeah, that are all the rage to talk about.
Lipo.
Yeah.
That was really good. I'm glad you brought that up because that's what I want to talk. So those are like the newer generation cholesterol things to worry about. Okay.
Yeah. Tell us about them because no one knows what they are.
Yeah.
Or what to do. They just hear it.
LDL, that is like so 1990. Like, give me my snack wells. You know what I mean? Do you remember that whole thing? Yeah.
Yes. Oy.
Disaster.
Yeah.
So these are other types of cholesterol particles that give us information about a patient's risk. Okay, so let's talk about ApoB. So ApoB is a protein that's found on almost every cholesterol particle that can cause problems, right? So it's another way of looking at how many cholesterol particles are there, right? And which gets to the point that when you look at your LDL cholesterol, right? We give you a number, and the number, let's say your LDL is 50, right? So it's 50 milligrams per deciliter. What you don't know is, do you have 51 milligram particles in there, or do you have one 50 milligram particle in there? Right?
So about the size, the size of the particle?
Yes, that's right.
So it's all about size. Okay.
It's about size because size matters, right? And I'm sorry, there was no way around it.
That's all right. We'll run with it.
So we know that different particles act differently. So some patients have small, dense LDL particles. That tends to be more atherogenic. That's more dangerous, causes more problem than large, fluffy LDL particles. So knowing how many particles...
So we want large, fluffy?
Yes, you want
large, fluffy.
Just like matzo balls. You want the large, fluffy matzo balls and LDL particles.
Okay.
Great.
So that it's another way of saying not just what's the concentration of my cholesterol, but is it the kind of cholesterol that is more likely to cause a problem, yes or no? So that's the ApoB story, and you want that as low as possible. You want that number very low.
Okay.
Lipoprotein A is different. Lipoprotein A is more similar to LDL. It's a lipid particle that is also very atherogenic, so it's correlated very highly with heart attack and stroke, also with aortic stenosis, which is a type of valve disease. The interesting thing about LPA is right now it's in that HDL place, which means we know that the higher the LPA, LP little a, the higher the LP little a, the higher the risk, right? But what we don't know is it a target of therapy or is it another marker? Okay. So this is relevant and very relevant because there were new drugs that were developed which can very extremely effectively lower LP little a, very effectively, like 95% reduction.
Wow.
Okay.
And it's RNA-based therapy. So they work in kind of a novel way to lower LPA. Seem to be very well.
You don't know if it's actually necessary yet because you don't know if it's a marker.
Well, you don't know if it does anything. So it lowers the number. Who cares? But does it decrease the risk of dying from heart disease? That is what.
Okay.
It's the proteins that are on the LDLs, like on the cholesterol molecules.
It's similar to LDL, but it just has this other protein on it called the lipoprotein little a. So it's pretty similar. Lipoprotein, these particular particles are not affected at all by standard therapy, right? So the statins do not change it at all. Lifestyle does not change it at all. It's completely genetic. Some of the newer cholesterol medicines lower it a little bit, 20%, but nothing to any significant amount. So
do you test for the ApoA and the ApoB, or is that not part of your standard of care?
I'm not a huge believer in it. I haven't been a huge believer in it. I think, so let's say the ApoB. The ApoB, I'm meeting a new patient. I'm trying to figure out your risk. How much should I worry about you and your risk of heart attack? I go right to coronary calcium score. That's me. I don't want to guess. I just tell me yes or no, you have it, right? So that's what I do. Other people want to, look at the ApoB and talk about family history and this and that. And I'm like, that's great, but I have a way to get to the answer. Why are we doing that? So I don't do a lot of it.
Okay.
But lipoprotein A, that's a totally different animal, right? Because that may be a new therapeutic target that everybody will. Once we prove that the drug reduces events, everybody will be checking LP little a.
Okay. So we need more information still.
It's kind of in that gray area.
Okay.
Yeah, I think, like I said, we know that it lowers the level, but the question is, does lowering the level lower the risk of actual events? And we're all literally the cardiology community sitting on pins and needles waiting to hear the results.
Okay. So for now, the calcium score is really big. Then you look at the cholesterol, and do I need to help lower the LDL and do some lifestyle changes?
Yes.
And put you on statins so that we can lower your calcium score. That's the idea.
Actually, not exactly your calcium score. So we never recheck your calcium score. So that people ask me that all the time. They said, I had a score of 87. You put me on medicine. I want to recheck it and show that it's better. It doesn't work that way. In fact, your calcium score may go up if we treat you appropriately, because one of the ways that the statins decrease the risk of plaque rupture is by helping calcify the plaque. So as I said in the beginning, calcified plaque is stable plaque. That is not the enemy. The enemy is unstable, soft plaque that ruptures. So unless you get a 0, all you need is 1 calcium score. Missy, you got a 0. That has to be repeated in 3 to 5 years.
Okay. So wait. So that I'm clear, because I'm confused. The plaque is what ends up building up along your arteries, and that's mostly from lifestyle and genetics, but genetics sounds like big deal. And then the calcium is your body's way of plastering the plaque up against. But if it's plastered there, then it sounds like it's not dangerous anymore unless you keep adding the plaque and adding the calcium.
That's
but
right.
At any point, that calcium and plaque could break off and kill you.
Correct. Yeah, you're totally right.
But there's no way to reduce what's already there?
Well, the statins do. So the statins and cholesterol lowering, they remove plaque from the lesions. They
do.
Make them smaller, and they increase the calcification. So they make those stable. And as I said, those can progress, but when you get one of those that's 90%, you come to me and you say, hey, when I'm walking the dog, I get chest pain. We know what to do. We put a stent in that fixes it, which is very different than the ruptured plaque that just ruptures and you're a goner.
So like if somebody tells me they got a calcium score of whatever, like 100, even if they live the rest of their lives doing everything they're supposed to do, at any point that could break off and kill them?
Yeah.
Yikes, dude.
I didn't make it up. I'm just saying.
And there's no lifestyle change, nothing we can do to reduce.
No, we are. Everything we talked about lowers your risk.
Okay.
Everything we talked about lowers your risk. Yeah.
Well, if they get that 100, they're getting a statin and they're getting lifestyle changes.
So here's the problem. That person, before they had the calcium score of 100, they thought they were fine. They thought their cholesterol, whatever it is, was fine. And their internist probably did too, because they didn't know they had coronary disease.
Right.
So they pat them on the back, keep up the good work. We'll see you in a year. Meanwhile, they have plaque that's unstable and has the potential to rupture and kill them. So once we find that calcium score of 100, then we start saying, okay, we need to lower your cholesterol. You need to go on aspirin. You need to start exercise. Then you get your stuff together.
But does that just slow the build, or does that reverse it?
Both. So.
Okay. I feel better now.
Yeah. If we can get your cholesterol down low enough, which is an LDL under 70, the majority of people, their plaque will regress.
Okay. Phew.
Yeah.
Thank you. I guess I missed that part. I don't know.
Yep.
Missy's all freaked out over there.
Now I get it. Yeah.
But the zero has to be repeated because the reason is patients can have soft plaque. So in other words, remember we talked about they have plaque that deposits in the arteries, but your body, for whatever reason, hasn't thrown the calcium at it yet. right? So the
Okay.
soft plaque is there. It still puts you at risk of having a heart attack and ruptured plaque, but we
Mm-hmm.
would miss it on a calcium score. We would miss it because there's no calcium to pick up, right?
And what
So
would
that
grab it then? What would pick it up? The cholesterol test or?
no, no. So this is the Achilles heel of coronary calcium scores, right?
Okay.
And it's more common in younger people. So that's why if Missy, you need to repeat that calcium score in 3 to 5 years, because half the people that have a zero will go on to become non-zero when your body catches up and calcifies the plaque, right?
Okay.
So my approach is if I have somebody who has a score of zero, and to be clear, a score of zero means you're at low risk for sure, but not zero, right?
Mm-hmm. Mm-hmm.
What I do is I look for other ways to find plaque that don't depend on it being calcified. So I'll look in the neck arteries, right? Ultrasound of the neck arteries, that picks up all types of plaque, calcified, soft plaque. It's easy to do. It's not, and can help us figure out what's going on.
Okay. So if I don't have any health issues and I don't feel any reason to have you look at the arteries in my neck and my calcium score is 0, I still at any moment, this is my phobia, could just drop dead from the plaque breaking off because it's not calcified.
Yes, you could.
Okay.
You also could be hit by falling space debris.
Okay. All right.
So the risk is low.
Yeah. I mean, if your score was 1,000, your risk would be here. If your score is 0, your risk is here, and then there's everything in between. So, nobody is zero risk, but having a score of 0 means your risk of having a heart attack the next 10 years is less than 1%, right? So it's
All right, I'll
low.
take it.
There you
It's
go,
good.
Missy.
It's
You're
good.
more
It's all
likely
about
to be
me.
like hit by a bus or something. Yeah.
Sorry. Hypothetical. It's a hypothetical. Okay, sorry. Please
Well,
go
at least
on.
now you feel better.
A little.
So, okay, is there any new data in the world of cardiology that's coming out that we should be aware of or changes the way you practice?
Yes. So a couple things. One, we talked about these LPA lowering drugs, right? The other one, which I'm sure you guys are talking about, are the GLP drugs, right? So the
Yes.
Ozempic and
Wegovy.
Zepbound and those sort of things. So
Yeah.
semaglutide and tirzepatide. Surprise, these are cardiology drugs. We stole them from the endocrinologists. They show amazing reduction in risk of dying from a variety of different heart conditions. And so this is in diabetics and non-diabetics, right? So
Wow. Okay.
this is a brand new tool for us that I've been heavily adopting. For, the ideal patient is somebody that has high blood pressure, diabetes, is overweight, has obstructive sleep apnea. And coronary disease. I can address each one of those things with this drug. And in fact, what I've found is I've been able to get people off some medication by using these drugs. So
That's amazing. Wow.
it is amazing. It
So
is.
I've heard that insulin levels going up and down. So if you're insulin resistant or if you are diabetic and you've been putting that strain on your body, getting there, that it puts a lot of actually strain on your circulatory system and your cardiovascular health. So is that kind of what it's addressing? It's sort of like letting them all sort of recover from.
Yes.
Okay.
Yeah, absolutely. I mean, but that's not the whole story because the non-diabetics see the same benefit, right?
Okay. Wow.
Right.
So
So
in cardiology, is this going to be you're on it for a lifetime, we don't wean off, or is it you stay on it until we see everything
that's what we don't know.
rectified?
That's what
Okay.
we really don't know. And we're all kind of trying to figure this out as we go. I'll tell you, my approach, again, is what are you trying to get out of it, right? If you're trying, so if your main goal to go on it is to reduce your risk of having a heart attack or dying from heart disease, then you probably have to do what the trials did, which is get to a maximal dose and stay on it. Okay.
Okay. And is insurance covering it for these diagnoses too?
It's not great. It's not
Okay,
great.
because I know it's
Okay.
not great for
Yeah,
other
it's not
coverage
great.
too.
I think it's pretty good for diabetes, but I mean, we have mortality data. Mortality, you will live longer in patients with coronary disease, patients with kidney disease. It's approved as a treatment for obstructive sleep apnea, but the insurance companies, I think, are balking a little bit because of the expense. But The good news is there's
Yeah,
there's
very
workarounds.
safe.
So like the manufacturers have released it direct to consumer, so that's considerably cheaper. And then, there's been lots of stuff in the news about ways to make it cheaper. So I would just stay tuned. But I think that's a major, major story in terms of reducing multiple medical problems in patients who really were headed for disaster, right? I mean, I had patients that were 300 pounds with high blood pressure and sleep apnea and diabetes. And believe me, they didn't want to be that way, but they didn't know what to do, you know?
So
And
this is a game changer
This
for
is
them.
great.
absolutely. I mean, we've been banging them over the head for 30 years about you need to exercise. You need, I mean, it's just not practical. So I think my approach, Stacey, you asked about do you stay on it forever? I think of it as like you start the medicine and, we'll see some initial weight loss. And then, we get to 6 months out, a year out, and then we have the discussion about can we try to wean it, right? Can we, instead of taking the same dose every week, could we take it every 2 weeks or every 3 weeks? And I think it just depends on the person. So if the person was they were a late night snacker, right? And they stopped late night snacking, which you do on these medications, and you internalize that and you don't keep doing it, then you should be able to survive without the medication, right? Same thing with portion control, right? Like if you can retrain yourself to do portion control and stick with it, maybe you don't need to be on the medicine forever. My experience, though, is that most people probably never get off of it completely.
Okay.
And Stacey, I would say too, by the way, when you had high blood pressure, nobody said take this medicine for a month and it'll cure your high blood pressure, right? Like it's the same thing. And furthermore, if I could put you on one of these drugs and get you on less blood pressure medicine, less other medicine, then that's a net win.
Okay. That's good to know.
Okay. Dr. Eimer, I don't know if I want to know the answer to this, but what's the truth about caffeine, alcohol, and heart health?
All right. Great question and very controversial. And I feel like we keep getting different looks at this, like it's good, it's bad, it's good, it's bad. I think that the same for both. I think in moderation, they're both healthy, right? And let's look at the data. The data on alcohol is that if you're consuming in the 1 to 2 drinks per day, you have decreased mortality, right? It's healthy. But then beyond that, the mortality starts to go up again, right? So if you're having 2 to 3 drinks a day, that's not helpful, right? So what I tell patients is stay in that 1 drink a day, and you cannot save them all up for Saturday. That doesn't work. Never works.
Okay.
The binge drinking is terrible, no doubt about that.
Okay.
But if you're the kind of person that likes to have a drink a day, I think it's fine. And by the way, every patient I have who's 90 plus and killing it, I ask them what do they do, and a lot of them have a drink a day, right?
Okay.
And so the problem is that I'm not sure there's any randomized controlled trials, right, against placebo, right? So I don't think we're ever going to get perfect data on this. And there are a lot of confounders, but I'm a 1 drink a day kind of person. I think that makes sense.
Okay. What about caffeine?
Coffee too.
Yeah, coffee, kind of the same thing. Although I hear less negative stuff about coffee.
Okay.
I think there's a study that came out recently showed that it is protective, protects against heart failure, protects against coronary disease. So I'm a big consumer of it myself. I think it's healthy.
I do too.
Okay, good.
Because I like it and I don't want to give it
I
away.
agree.
Okay, what happens if you don't drink
Thank you.
caffeine or alcohol? Does that
Well,
get us
I
any
don't-
brownie points?
No,
Stacey wants brownie
it makes
points.
you a loser. I mean, nobody wants to.
You don't meet people for coffee. You don't meet
No.
out for drinks.
I drink
You don't.
tea occasionally.
And,
I drink
have
alcohol occasionally.
Home by yourself.
Not
I
daily for
have-
either.
a suspicion that part of the benefit of alcohol and caffeine is the relationships and the culture that goes around it, right? Like if
Okay.
you're drinking in your closet every night, I'm not sure you get the same benefit as someone
Right.
who's
I like
with
that.
the family.
Drinking socially.
Yes. That's a really good point. That's
I'm a
really
social
good point.
drinker, and I drink tea
Okay.
occasionally.
Then
And
you're
I
fine.
I meet people for coffee all the time. I just don't drink coffee.
Okay, you're good, Stace.
Then
Stace is
maybe you're
good.
getting the benefit.
I'm good. You're good. I'm not going to drop dead.
We're all good.
You're not a nerd. Okay.
Okay. So this is a big one that people ask all the time. How do you tell if you are having anxiety or a heart attack? And I think as we age, that question becomes more and more common.
Yeah, I mean, I would say there's no foolproof way, right? I've been doing this a long time. I have seen every imaginable symptom actually be a heart attack, right? So I'll just say that, right? I can give you the typical picture, right? So like 9 out of 10 people when they're having a heart attack will go like this. They'll put their hand on their chest on their own and say, I feel a pressure, a heaviness, someone's standing on my chest, there's an elephant on my chest, there's a squeezing. That's what 9 out of 10 people say, right?
Okay.
They
What
don't
about
say
the
it's
arm thing? The arm pain.
yeah, so some of them, that discomfort, and they're all very clear about saying discomfort. They don't really say pain. They say this discomfort, it goes to my left arm, sometimes it goes to my jaw, sometimes it goes to my back,
I
right?
heard that too with your jaw. I read a story about a woman who started feeling it in her jaw.
Yeah.
And then she called 911. She's like, I think I'm having a heart attack. They're like, well, lay on the floor so you don't fall and hit your head.
Yeah.
And then they came and got her, but it was in her jaw. It was crazy.
The thing is sometimes bad heartburn can radiate up towards your jaw.
So this is why you need cardiologists, because I mean, you know how many people go to dentists and they're like, I don't see anything. Your teeth look fine. You better you better make sure you're not having a heart attack, right? Same thing, GI stuff, often confused with heart disease, right? In fact, tragic story in our own medical staff. Last week, one of our physicians died in the Walgreens parking lot getting acid medicine, right? Because he thought he was having a heartburn,
Reflux. Oh my gosh.
I heard that. I heard that story.
Oh,
I think that's my friend's
that makes
doctor.
me sad.
Yeah.
It's horrible. It's the worst,
So if it's like not something you normally get, like I don't usually get heartburn, and all of a sudden I'm like, do I have heartburn?
Yes. So I think that's the key, right? And heartburn usually is related to some kind of food, some kind of drink, some kind of position. But is there a foolproof way? No, there's not. There's not.
Okay. So 9 out of 10, they feel pressure. On their chest,
heaviness,
like someone's
squeezing.
standing on their chest. Okay.
The other things we hear about a lot are shortness of breath, right? So I'm short of breath.
That can be like an anxiety attack too.
It can.
Could it be your heart starts racing or no?
Yeah.
The anxiety attacks, usually your heart starts racing.
Yeah. I mean, anxiety attacks are more often, in my opinion, confused with abnormal heart rhythms, so arrhythmias. So fast heart rhythms more than heart attacks, right?
Okay.
So a racing heart is not a sign of a heart attack.
Racing heart is not a typical heart attack thing.
Okay.
Okay.
That's not
cool.
typical.
Good to know.
We like that. We like knowing the difference there.
Yes.
Yeah.
We're not anxious or anything.
I really focus on the pressure, the heaviness, the squeezing, that kind of stuff. That's what gets my...
Are there any other like early warning signs of trouble that we should be on the lookout for?
I mean, I would say another reason patients have to exercise is because if there's something wrong with your heart, you will initially notice it during exercise, right?
Okay.
Oh.
So that's like a little stress test you do for yourself every day. If you are a couch potato, you don't do anything, your heart could totally be falling apart. You won't know until it's very late. Right?
My dad, our dad had blocked arteries, and he was exercising and he got nauseous. And it turned out he had a huge blockage, but it was when he was exercising.
Yeah, so exertional symptoms definitely get my attention too, right?
Okay.
We didn't talk about nausea, but some percent of heart attacks really are nausea, vomiting. I mean, there's a specific place in the heart where that happens, which can be confusing too. But any exertional symptoms always get my attention, right?
Okay.
So again, exercise is good for your heart, but it's also good for your cardiologist in reassuring them that we're not missing anything, right? So if a patient comes in, I've been having this chest pain, and then I say, well, how's your exercise? And they go, oh yeah, I biked 20 miles this morning. I felt great. Not likely that that's a heart thing. You know what I mean?
Okay. Sure. Because they're not experiencing it while they...
Yeah.
Right.
Yeah.
So the exercise is not only beneficial for our health and overall and our fitness, but it's also beneficial as a measurement tool for you.
Exactly. Yeah, I think it's a reassurance that I'm doing okay. And if you're going to notice problems, it's more likely while you're exercising than not.
Well, this is a lot of really great information. I gotta tell you, Dr. Eimer, like this is going to be one of the most fun episodes. You are fantastic. You're a ham, and we're having a good time.
I told you he's everyone's favorite doctor. Everyone I know that goes to him.
Right.
It's like the favorite doctor.
Stacey's right.
Dr. Eimer, if you could give our listeners just 3 habits to improve their heart health, what would they be?
Okay, I love this question. And we talked a lot about this already. Number 1, exercise. That's for sure. Number 2, decrease your sugar intake, right?
Good one.
I think it's just trouble all around. Decrease your sugar intake. And the last one, I know you were thinking I'm going to say something about don't smoke or whatever. I was thinking about this in terms of the coffee and the alcohol. I think it's create and maintain helpful, meaningful relationships with people. And I think I'm not the first person to think of this, right? Like if you look at people who are married, people that are in quality relationships, they have less heart attacks, they live longer. There's something to that. And so I think exercise, sugar, and work on those relationships.
I love that.
Thank you.
Thank you. That's great. So here at the Digestible Podcast, we like to say, don't panic, just pivot. Is there a pivot you've made in your life, a small change that you would be willing to share with us that you're proud of?
I would, yeah. So when I graduated from medical school, I thought I wanted to be a surgeon. And I matched in surgery at a very prestigious program. And I got there, and within 3 months, I was like, I've made a horrible mistake. Horrible. I hated it. I dreaded it every morning. And, I was already in it for 4 years of medical school and college. And I'm like, I can't believe I got all the way here to hate my job. And I talked to some people, and I was like, what do I quit? Do I go into consulting? What do I do? And they said, no, just try something else. So I finished the year because I didn't want to leave anybody high and dry. And I started over in a totally different field. And it's hard to quit things. You know what I mean? It's hard to say, this isn't for me. You guys are better than me at this. I'm not good at this. It was very hard, but it was definitely one of the best things I ever did, was to say, no, you don't have to throw out the whole thing. Just look that way, and let's go that way. And it worked out great for me.
It worked out. Great. Thanks for that story. That's a good one.
That's a great story. And thank you so much for your time.
Yeah.
Yes,
my
we
pleasure.
loved having you. This was great.
All right.
Super fun.
Thank you for listening to the Digestible Podcast with this week's guest, Dr. Micah Eimer. Thank you for listening. If you like this episode, please share us with others. It's the best compliment you can give us. If you have any questions or comments, please email us at info@digestiblestrategies.com. We look forward to hearing from you, and remember, don't panic, just pivot. The content shared on this podcast is for informational and entertainment purposes only. We are not medical professionals, and the views expressed here are not intended to diagnose, treat, or cure any health conditions. Always consult with a qualified healthcare provider before making any health-related decisions.